Hey everyone, for all you healthcare providers and neurology residents out there, I know you're always looking for the latest in patient management.
Always.
Well, today we're going to unpack something that's been making waves in the neurology world.
Oh, yeah.
Myelin oligodendrocyte, glycoprotein antibody-associated disease.
MOGAD.
MOGAD for short, that's right.
Right.
And we've got two recent articles to guide us here.
Okay.
MOGAD, a comprehensive review of clinic radiological features, therapy, and outcomes in 699 patients globally from 2025's autoimmunity reviews.
Okay.
And what's new in NMOSD and MOGAD, published in Revue Neurologique, Paris
Yeah.
in 2024.
Sounds good.
And our goal, to equip you with some practical takeaways for diagnosing and treating this often misdiagnosed condition.
Great.
You know, one thing that really jumped out at me from that autoimmunity reviews article was just how prevalent MOGAD might actually be.
Oh, really?
They suggest it could account for up to 50% of demyelination cases in children. That's a staggering number, and it really underscores the need for a clear understanding of this disease.
It certainly does. It's crucial to be able to distinguish MOGAD from conditions like MS or NMOSD.
Right.
Especially because, timely and accurate diagnosis has a direct impact on treatment decisions.
For sure.
And patient outcomes.
Okay, so let's dive into the clinical presentation then.
Sure.
The review highlights optic neuritis, or NNO,
Right.
as the most common initial symptom in adults. However, in children, it's a different story.
Okay.
They often present with acute disseminated encephalomyelitis, ADEM.
Interesting.
So right off the bat, we see age playing a significant role.
And it's not just about the initial symptoms, it's about the nuances within those presentations.
Okay.
For example, the review found that 71% of MOGAD patients with ON present with papilledema.
Wow.
That's significantly higher than what we typically see in MS.
Yeah.
Making it a valuable diagnostic clue.
Right. And while we're talking about ON-AN, the review also noted something kind of interesting.
Yeah.
Ocular pain was actually less common in MOGAD-related ANO compared to MS.
Huh.
So it's not just about the presence of a symptom, but also its frequency and characteristics that can point us in the right direction.
Absolutely. Now, while the initial presentation can vary, long-term follow-up often reveals a pattern of relapsing honor,
Okay.
occurring in about 20% of patients.
Interesting.
This makes it the most common phenotype we see over time.
Speaking of relapses, there's another crucial point from the autoimmunity reviews article that really caught my eye.
Okay.
The proportion of patients experiencing relapses actually increases the longer they're followed,
Really?
reaching a staggering 72% after 5 years.
Wow.
This challenges the earlier view of MOGAD as primarily a monophasic illness.
Yeah, it most definitely does.
Yeah.
And this shift in understanding has significant implications for how we approach MOGAD management.
Yeah.
We need to be thinking about long-term strategies right from the get-go.
Right.
Even if the initial presentation seems mild.
Especially in children, it seems.
Yeah.
The review found that the time to the first relapse is much shorter in kids, about 6 months compared to 17 months in adults.
Oh, wow.
That really emphasizes the need for vigilance and proactive management in pediatric cases.
Precisely. Early intervention is key.
Right.
Especially given the potential for long-term consequences of repeated inflammatory attacks.
Now let's shift gears to radiology. The review uncovered some fascinating differences in MRI findings between adults and children.
Okay.
At the onset, MRI brain scans are more often normal in adults, about 50%, compared to only 27% in children.
That difference likely stems from the higher frequency of ADEM in children, which typically presents with more prominent abnormalities on brain MRI.
Right.
This highlights the importance of considering the patient's age when interpreting imaging results.
The age-related patterns get even more intriguing when we look at specific MRI findings. In children, the review noted more frequent lesions in the deep gray matter, cortico-subcortical areas,
Right.
and paraventricular regions. They were also more likely to have those characteristic H-shaped spinal cord lesions.
In contrast, adults with MOGAD were more likely to have eccentric spinal cord lesions and involvement of the intraorbital optic nerve.
Interesting.
These distinct patterns can be incredibly valuable in making a more confident diagnosis.
Okay, we've covered clinical presentation and radiology, so let's move on to other tests that can help solidify a MOGAD diagnosis.
Sure.
What about CSF findings?
One key difference between MOGAD and MS is that cerebrospinal fluid usually doesn't show oligoclonal bands in MOGAD.
Okay.
This absence can be a helpful indicator when trying to distinguish the two.
Right, and the autoimmunity reviews article highlighted another crucial biomarker.
Yes?
Peripapillary retinal nerve fiber layer thickness.
Right.
or PRNFL,
Wait.
particularly in cases of optic neuritis.
PRNFL measurements are a powerful tool. The article noted that the PRNFL often shows swelling initially,
Okay.
potentially offering an early diagnostic clue. Then about 6 months later, atrophy appears, correlating with long-term visual impairment.
That's fascinating. And the review actually suggests that PRNFL measurements might be even more sensitive at detecting visual dysfunction than standard visual acuity tests.
Absolutely.
That's something for us to consider when evaluating patients with suspected MOGAD.
It reinforces the importance of a comprehensive approach that goes beyond just the basic clinical examination.
So pulling it all together, we're looking at a range of clues, from clinical presentations and MRI patterns to CSF findings and specialized eye tests like PRNFL.
Right.
All these pieces come together to paint a clearer picture of MOGAD
Yeah.
and help us differentiate it from other conditions like MS and NMOSD. Now that we have a better grasp on identifying MOGAD, how do we tackle it?
Well, for acute attacks, IV corticosteroids are still considered the first line of therapy,
Okay.
much like in other demyelinating conditions.
Right.
The goal is to quickly control the inflammation. However, when it comes to maintenance therapies to prevent future relapses, things get a little more complex.
The Autoimmunity Reviews article pointed out some pretty significant regional differences in how MOGAD is managed long-term.
Right.
For example, in Australasia, there's a high use of oral prednisone and mycophenolate, while in the MENA region, azathioprine is more commonly prescribed.
Yeah.
It's fascinating how these geographic variations play out.
It is, and those differences likely reflect a combination of factors.
Yeah.
Access to certain medications certainly plays a role, as does cost.
Right.
Some therapies are simply more expensive than others,
Right.
which can be a major barrier in some parts of the world.
And then there's the role of clinical experience and regional preferences.
You're right. Clinical practice patterns can significantly influence prescribing habits. And of course, we can't forget the constantly evolving nature of research.
Right.
New studies are constantly emerging.
For sure.
And those findings can lead to shifts in how we approach treatment.
Speaking of new research, the Revue Neurologique Paris article touched on the potential of eculizumab for acute MOGAD management.
Oh, interesting.
It's currently used for NMOSD, but there are some promising case reports suggesting it might be effective for MOGAD as well.
That's exciting.
This is an exciting development, especially given its proven track record in NMOSD.
It's definitely promising, but it's essential to note that the data on eculizumab for MOGAD is still quite limited.
Right.
We need larger, more robust clinical trials to confirm its efficacy and safety in this specific population.
But even so, it's encouraging to see that we're not limited to the same old treatment options.
Absolutely, and it's not just about new drugs.
Yeah.
There's also growing interest in personalized medicine approaches,
Okay.
tailoring treatment to each individual patient's unique genetic and immunological profile. This is particularly relevant for MOGAD, given the variability we see in how people respond to different therapies.
That makes perfect sense. By understanding the underlying mechanisms driving the disease in a specific patient, we can hopefully select the most effective treatment for them with the fewest side effects.
Exactly. It's about moving away from a one-size-fits-all approach and towards more targeted, individualized care.
Okay, so we've covered a lot of ground here, from the initial presentation and diagnosis to the complexities of treatment. But before we move on, I want to take a step back and think about the bigger picture.
Okay.
Both articles highlighted the importance of peripapillary retinal nerve fiber layer thickness, or PRNFL,
Right.
in understanding MOGAD, especially its potential for predicting long-term visual outcomes. It makes me wonder, could monitoring changes in PRNFL actually help us make more informed decisions about treatment and maybe even guide the development of new therapies, specifically targeting visual dysfunction in MOGAD?
That's a very insightful question, and one that definitely deserves more attention as research in this area continues to evolve.
It's something for all of us to consider as we apply these insights to our practice.
Absolutely. You know, one of the things that struck me from the Autoimmunity Reviews article is this idea that MOGAD might be even more diverse than we initially thought.
Right. It's not just a single disease, right? But a spectrum with a range of presentations and courses. This is where understanding the different phenotypes becomes so crucial.
Absolutely. We need to be able to recognize and differentiate these subtypes to provide the most targeted and effective care. Think of it like having different tools in your toolbox.
Okay.
You wouldn't use a hammer for every job, would you?
Makes sense. So let's explore those tools, shall we?
Sure.
What are some of the key MOGAD phenotypes that stand out from the research?
Well, as we mentioned earlier, relapsing on is the most common phenotype we see long-term.
Okay.
But there's also monophasic on,
Right.
where patients have just one episode and then it resolves. The challenge lies in knowing which path a patient will take early on.
And what about edema in children?
Right.
We talked about it being a common initial presentation.
Yes.
But does it tend to follow a monophasic or relapsing course?
That's the tricky part. It can go either way.
Really?
We see both monophasic and relapsing edema in kids.
Wow.
Which just reinforces the need for careful monitoring and follow-up. You really have to stay on your toes with these young patients.
So even within a specific presentation like edema, there's still a lot of variability in how the disease might progress.
Exactly.
That must make predicting long-term outcomes pretty challenging.
It absolutely does. We're still learning about the long-term course of MOGAD,
Yeah.
but the research does point to some potential prognostic indicators.
Like what? What should we be paying attention to?
Well, the severity of the initial attack seems to play a role.
Okay.
Patients who have a more severe first episode might be at higher risk for long-term disability.
That seems intuitive. What about the frequency of relapses? Does that impact the long-term outlook?
Yes, definitely. More frequent relapses generally correlate with a higher risk of accumulating disability over time. It's like wear and tear on the nervous system. Each relapse can potentially leave its mark.
The review also mentioned that the specific phenotype itself might influence prognosis, right? For example, patients with relapsing on might have a different trajectory than those with monophasic edema.
Precisely. We're starting to unravel those phenotype-specific prognoses.
Yeah.
But more research is needed to really solidify our understanding. It's like piecing together a giant puzzle.
And of course, it seems like early intervention and effective treatment are crucial for improving long-term outcomes.
Absolutely.
The sooner we can control the inflammation and stop those relapses, the better the chances of preventing lasting damage.
Absolutely. Every attack has the potential to chip away at a patient's neurological function.
Right.
Our goal is to protect them from further damage.
All of this brings us back to the importance of an accurate and timely diagnosis. If we misdiagnose MOGAD as MS or NMOSD, we might not be using the most appropriate treatment,
Exactly.
which could have long-term repercussions for our patients.
You're exactly right. A misdiagnosis could lead to delays in appropriate treatment, which could mean more relapses and a greater risk of permanent damage.
So far, we focused a lot on the physical aspects of MOGAD, but it's important to remember that there's a human being behind every diagnosis.
Absolutely.
What about the emotional, social, and cognitive impacts of this disease? How does MOGAD affect a patient's overall quality of life?
That's a crucial point.
Yeah.
Living with a chronic, unpredictable illness like MOGAD can take a toll on mental health. Imagine living with the constant fear of another attack, not knowing when it might strike or how severely it might affect you. It's no surprise that many patients experience anxiety, depression, and a sense of uncertainty about the future.
Plus, the symptoms themselves, like fatigue, vision problems, and mobility issues, can significantly disrupt daily life, making it hard to work, socialize, or simply enjoy the things they used to.
Yeah,
It's a huge burden to bear.
it is, and that's why it's so important to address these broader aspects of MOGAD, not just focus on the physical symptoms. We need to think holistically.
So what can healthcare providers like us do to support patients in a more holistic way?
First and foremost, we need to be good listeners.
Right.
We need to validate their experiences, acknowledge the challenges they're facing, and let them know they're not alone. We should be connecting them with resources like support groups,
Okay.
counseling, occupational therapy, anything that can help them cope with the emotional and practical aspects of living with this disease.
The Autoimmunity Reviews article also mentioned the importance of addressing cognitive dysfunction, which can sometimes occur in MOGAD.
Oh, right.
Cognitive issues like memory problems, difficulty concentrating, and slower processing speed
Yes.
may not be as obvious as physical symptoms, but they can be just as debilitating.
Absolutely. These cognitive symptoms can affect a person's ability to work, study, and maintain their independence.
For sure.
We need to be aware of these potential problems and refer patients for neuropsychological evaluation if needed.
Early identification and intervention are key,
You're right.
just like with the physical symptoms.
It's all about empowering patients to manage their condition and live their lives to the fullest.
As we move into the final part of our discussion on MOGAD, I think it's important to remember that this disease is more than just science and statistics. It's about real people whose lives are deeply affected by this condition.
Absolutely.
We, as healthcare providers, have a responsibility to stay informed, be compassionate, and advocate for the best possible care for our patients.
I couldn't agree more.
Hopefully this conversation has given our listeners some helpful takeaways and sparked some new ideas for their own practice.
I hope so.
And to our listeners, we encourage you to check out the 2 articles we discussed today.
Yes, definitely.
MOGAD, a comprehensive review of clinic radiological features, therapy, and outcomes in 699 patients globally, from autoimmunity reviews in 2025, and What's New in NMOSD and MOGAD, published in Revue Neurologique, Paris, in 2024.
Great articles.
These articles provide a wealth of information about this evolving condition.
They do.
And remember, knowledge is power.
Absolutely.
The more we understand about MOGAD, the better equipped we'll be to diagnose it accurately and provide the best possible care for our patients.
Couldn't agree more.
Thanks for joining us on this deep dive into MOGAD. Disclaimer and a bibliography in the description. And please share your thoughts and experiences in the comments.
Yes, let's keep the conversation going.
Let's keep the conversation going.